Welcome, everyone. We are so excited to have you all join. As always, thank you for joining. Thank you for being here. Happy Wednesday. And we hope that you will let us know who you are and where you're joining from in the comment pane on your right-hand side of your screen. And make sure you say hello.
Oh, you muted yourself.
Wasn't that something? We are so excited for today and this topic because I think it's something that Chris and I and others are just so passionate about, but we are so excited for our guest who is even more passionate and knowledgeable than any of us in this topic area. So we will get into introductions in just a second. Before we do, a couple of reminders. These live streams are not intended to replace therapy. They should be used as an opportunity to gain education, hopefully insight, and maybe some resources. But we really want you working with your own individual clinician for individual therapeutic questions or concerns. And of course, IOCDF and or the live streams are not crisis hotlines. If you're feeling unsafe or suicidal, please go to your local emergency room, call 911, or call the suicide prevention line. Of course, for those of you who join internationally, please use your resources that are there. The biggest update Chris and I just keep talking about, we want to keep talking about, is we will get to see each other in the flesh soon, which is in Denver. So please make sure, if you haven't already, to consider registering for the International OCD Conference. This is an incredible place where professionals, individuals, and family members all come together, and we spend a weekend learning and growing together and building our own incredible community. So please make sure you go to iocdf.org / I think OCDCon is the URL. Is that right, Chris? Do you know?
If you go to, I think it's iocdf.org conferences.
Yeah, okay, conferences. I'm always wrong. So go there and make sure you register. It is the second weekend in July. It'll be in Denver, Colorado, and we are so excited to see everybody there. So let's hop in. I am going to start. So Dr. Lauren Wadsworth is an incredible professional advocate and what I'm lucky enough to say also a friend and colleague. So we get to work together and talk together in different arenas, but we're just so excited that you are here. Dr. Wadsworth serves as a senior advisor to the Diversity, Equity, and Inclusion Office at McLean Hospital and Harvard Medical School. She's also the founder and director of the Genesee Valley Psychology, GVP, which is an OCD clinic providing evidence-based care to the Rochester, New York area. Dr. Wadsworth runs this clinic that is a specialty OCD clinic. And so she's the clinical senior instructor, also is the clinical senior instructor in psychiatry at the University of Rochester Medical Center. What you didn't mention is that you are also an author, that you co-authored the book, Did That Just Happen? Beyond Diversity, Creating Sustainable and Inclusive Organizations, and alongside Dr. Stephanie Pinder-Amaker. You are also, are y'all the co-founders together of the Twin Diversity Trainers? Okay, so you guys do so much. And for those of you who haven't read the book, I would go grab it, but it's on my bookshelf, so I'd have to walk over. But our entire organization here in Houston read the book together because we really wanted to think about two things. We wanted to think about how do we better serve marginalized populations as like within our team culture and who we are, but also how does that apply to patients? And that's exactly what we're going to spend today doing. We're going to spend today talking about from both a clinical or clinician perspective and a patient perspective, what does us better understanding ourselves, our communities, our values mean when we think about practice and we think about how it can be implemented. So Lauren, thank you so much for joining us. We're so excited to have you here. If you want to share any words or insight about why you're excited about this topic and why justice-based ERP is important to you, we'd love to hear.
Sure. Thank you for the awesome introduction, Liz. And thank you, Chris and Liz, for the invitation to be here. It's really humbling to be here among giants, and I'm really excited to have a conversation with the two of you on two of my favorite topics, OCD and DEI work. It's rare that the two happen in the same room for me, so I'm really excited to dive in.
Well, we are so excited. And Chris, I'll share first, and then Chris, I want to hear from you. But, I think one of the things I've been thinking a lot about, I don't know how you guys feel, is there's so many thoughts, theories, insights around how to treat OCD in general, right? So like if you read through our Facebook group that the clinicians, a lot of us are a part of, or you start reading different people's perspectives of like, what language should we use? How do we, what does ERP actually look like in practice? There's just so much. And I find myself sometimes getting really lost. But what I also love is that I feel like as a community, we are really shifting towards continuous growth. versus being stuck in an old pattern of like, well, this used to work, so why change? And I actually remember in grad school when I was even doing my postdoc, I remember being told once, like, why are you worried about third wave modalities? Like, we know ERP works, why shift? And it was, and while I agree, like I'm certainly a strong behavioralist and love ERP, I want us to always be open-minded to thinking about, can what we do be done better, be done more effectively, and be done in a justice-based way. And I'm just so excited for us to spend today talking a little bit about the history of ERP and times where actually what we were doing may not have been helpful for certain populations, but also even our own growth and understanding as individuals with OCD and how we can shift that. But Chris, tell us why it's important to you and what you want to talk about.
Yeah, no, my mind has 3 points. So I'm gonna make them really quick. I mean, I think the first point is I just remember in undergrad, I had a professor and, she was just talking about like in her community, she's Black, and she was just saying, her daughter needed to see a psychiatrist and felt more comfortable working with a Black psychiatrist, and that there was only 3 in all of LA County at the time. And I just, that boggles my mind, just thinking like, if you're wanting to get care, it's your first time getting on medication, and somebody who understands the unique challenges of your community, and you want to kind of connect with them and talk with them, there's 3 options for you. And that's something that kind of gets missed for a lot of us. So I definitely think that always kind of stuck with me. So it's always been a passion of mine, is like, how do we get more communities involved in mental health care, but also OCD in general? How do we get the conferences to more reflect the individuals with OCD? How do we get the talks and the topics? I would say second, I think a lot of times different clients have come to me, and it's almost like certain communities have been used as props in their OCD treatment. I think one that's always stuck with me is we have a large like houseless population in one of the cities nearby, and a client came to me and was talking about some treatment he was doing, and it was almost like the therapist kept using them as props. And I'm like, okay, well, yes, we do need to expose you to that situation, but what if we did it something based on values like community work or something like that, versus just like showing up and having to like run up and like hand them $1 and touch it. It just felt very icky. So I think that. And then lastly, we had a great conversation for a recent lunch and learn just about how to make OCD based working with LGBTQ populations. And I just heard a lot of feedback that spoke to a lot of individuals. And I know this conversation will as well. So I'm just really excited about it. And I think as clinicians in general, this is a topic that we want to keep growing on as a community.
Totally. Lauren, any thoughts for you of just like why the intersection? I mean, I know how much it means to you because it's what you do every day, but why this intersection is important for us to be talking about and thinking about clinically, and for patients, the value it can have for them and in their treatment.
Yeah, I think that something you said, Liz, really stood out when we've thought about, even in our typical stance of ERP works and a little bit of ACT here and there can be helpful, we still aren't frequently talking about the ways that identities, particularly marginalized identities, could be interacting with symptoms or could interact with safety of doing certain exposures. So I've done a lot of work to develop worksheets and exercises that can help distinguish safety and non-safety or threat or danger in designing exposures. But I think it's something that we need to do a lot more on, both in our own reflection as therapists, in our discussion on teams, how we present cases, how we do intakes, how we design exposures, and how we understand the therapeutic dynamic. So there are billions of things we could say about any one of those parts of the therapeutic process. But it's something that I've never met a team that has been doing this perfectly. I don't think that exists. So it's something that we all need to learn how to do better at on a consistent basis. And the more we talk about it across discipline, across specialty within OCD, across role, the better we're going to get.
100%. And I'm making notes about things I want to make sure we talk about later, because you just brought up a couple ideas in my mind that I'm like, oh, how could we do that in practice? And what does that look like? So we'll get there. But first, let's really lean into justice-based therapy for kind of clinicians and broadly. And so when we're really thinking about what can clinicians do? So ourselves in the field, what can we do to make therapy and intakes more affirming and justice-based? Would love to hear your thoughts on that, and would love to hear just kind of some simple maybe do's and don'ts, but just really like, what should we be doing? What should we be thinking about? And how does that change our work as we know it?
I think one really simple thing is doing an addressing interview at the intake session. So Dr. Pamela Hayes is a psychologist in Alaska who you might be familiar with her cultural humility work. She designed the addressing acronym, which is probably the world's longest acronym. It's literally every sociocultural identity that we have that's been historically marginalized in the US. So age, diagnosis, status, disability, religion, race, ethnicity, sexual orientation, SES, indigenous heritage, nation of origin, and gender identity and gender expression. And one of the ways that we've increased our cultural humility and responsiveness at our clinic is to ask patients, session 1, how they identify across this whole acronym, and in what ways are those identities influencing what you came in for, influencing your treatment, influencing access to treatment, like things like telehealth or the ability to get here on time. What strengths or supports come from these identities? How can we use that to enhance and improve treatment when times are tough? And then just opening the door to talk about the identities that we share and don't share that you can see and how that might influence our work together. So that could be an hours-long conversation, but we do at least 10 minutes with every patient to use Kenneth Hardy's words, broker that conversation, using our power and our privilege to open the door to talk about identities, and in doing so, do a pretty thorough assessment of patient identity to get to know them alongside the symptoms that they're coming in with.
I love that. I'm taking rigorous notes, and I hope other clinicians are too, just because this is so important. Chris, I know you had a thought.
Yeah, I wanted to ask, what has been the feedback for clients that have come to your practice that may have come from other practices and didn't get that? I mean, I know, obviously certain clinicians deal with it different ways. And I know, those of us that are trying to be as cohesive as we can, not everybody is. And obviously there's like you were saying, there's always work to be done. But what's been some of the feedback going through that intake process? And what have you heard from some of the people that have really appreciated that, some of the things that they felt heard or seen that they may have not felt in other therapy?
Yeah, I mean, especially in the OCD world. So we have a few different arms of our clinic, but especially those that are coming in for OCD will often say things like, I've never been asked any of my identities in therapy. Especially if I've gone to a specialty OCD clinic, it's just, all right, what are your symptoms? What are you avoiding? How do you ritualize? All right, let's address those. Folks have assumptions made about what their pronouns are, what name they like to go by, just based on insurance cards and intake paperwork. So just wow, thank you for asking. We expected more pushback from folks that hold a lot of privileged identities, say, why do I need to do this whole assessment? Obviously, I'm a man, and microaggressions like that. But we don't actually have a lot of pushback. And folks that identify as privileged across that acronym might say, yeah, I feel pretty guilty about this. That might open up a whole conversation. Or they might say, you didn't ask about this aspect of my identity. That's something that's really significant. So for example, I have a kid with a severe disability, and that influences a lot about my treatment and my access to treatment. So can we talk about that? Another thing that's been really cool, which I see as a sign of trust, is that folks have given us feedback on how we can improve that assessment. So every 3 months, we meet as a team to compile our own personal reactions to how we do the assessment and patient feedback. And then we enhance it, we change it to get at things in a better way, in a more respectful way. And the fact that people are contacting us and saying, hey, by the way, in my intake, they asked this question, I recommend doing it this way, to me shows that they think that we would respond to that feedback well, and that it's worth the time to educate us. So that's been really exciting to see as well.
That's awesome. So when we're thinking about, we were just talking for a second about accessibility and like the impact that it has for patients. What can clinicians do to make ourselves more accessible? So like, are there any, I guess in general, right, I think we all have some generic thoughts of like making treatment more affordable or having options, right, where people know about us, or like, are we, engaging in community awareness? But from a social justice perspective, what can we be doing?
Do you mean like how we are in the room, or?
Yeah, in the room and creating opportunities where the space feels really safe.
Yeah. Well, there's a lot that can go into that. I know that for us, we've really worked on using a lot of the stuff from the book, Did That Just Happen, to create an inclusive team so that folks of color, folks with minoritized gender identities might be more willing to join our team, and when they get there, might be more willing to stay. So I think that team diversity has been something that we've really prioritized, both in pushing our personal growth and our teamwork and our team growth on cultural responsiveness and humility. I think that the more diverse your team is, the more you're going to be able to have these conversations within your clinic and push each other. The more you work on it, the more trust there will be, the more feedback there will be. And I see that as the main, the golden goose, if you will. It keeps laying eggs and keeps having helping the whole team grow. And I think that has a trickle-down effect into how we are in the therapy room. If we're learning how to work with colleagues with different identities and having brave conversations together, then we can start to do the same thing with our patients. But some general specifics, I think when you meet a patient at the front door, if there's a step or elevator option, not just assuming they can use the stairs, offering the elevator is one way to signal inclusivity and that there could be invisible disabilities that folks have. Asking folks in the intake, what name do you go by? What pronouns do you want me to use in session? Being aware that those pronouns might be different than what their family uses, and being really careful about not outing teens or adults that have minoritized hidden identities like sexual orientation or gender. And just really making sure you're talking about that with your trainees as well, so that you're not having the same mistakes happen over and over. We're sharing the mistakes that we're making as clinicians with our trainees so that hopefully we can do less harm. But I could go on and on about financial models of accessibility. That might be another talk.
Do you have any thoughts? I guess one thing I'm wondering too is, do you have any thoughts about ways to increase accessibility for clinicians who use a lot of online profiles? So like, is there things that we should really be highlighting when we talk about the work that we do, whether it's through our IOCDF listing or someone's Psychology Today listing, that may make it more apparent to others that like this is an inclusive clinician where I'm not going to feel, hopefully I won't feel marginalized or judged, but instead I will feel safe?
Yeah, I think that two thoughts come to mind. One, that folks that are out there that are watching this that want more patients and think that one way they could do it is to say, I'm an inclusive therapist, without really having done that work. I'd say, please don't do that. Please only check this box if you've done a lot of self-work, you self-identify this way, you have an active group or person that you're getting feedback or coaching on this. Because if we muddy the waters, that item isn't going to mean anything, right? It's like on Psychology Today when everyone checks OCD, CBT, DBT, psychodynamic, like none of those things matter anymore. And if you were to indicate or want to communicate that you think you might be safer than others, try to be behaviorally specific as to how. So
why, right?
I really value cultural humility and responsiveness. That means that I engage in weekly reading and team dialogues around microaggressions and how they're coming up in the therapy space. Like, just be specific.
Yeah. I love that. Don't make it be another one of those check boxes, because one of the things we talk about is when clinicians check like 100 things they do, you're like, how do you specialize in 100 different things?
Right.
That's impressive. Like,
well, speaking on that, I mean, obviously your book is a good place for people to start. We got to push that.
And the link is here. People can find it on the pane on the right.
Also, for clinicians, let's say, I mean, I think, I know you're in New York and I'm in California, and there's a lot of access to different workshops, both virtual or in person. What are some of the ways that you recommend for a clinician that does want to learn how to work with different marginalized groups and be a lot more competent and do DEI work? Where are some places that they can start, whether it's books, trainings? What are some of the things that you see in your own practice where you pull from that has been really helpful to help educate your staff or just clinicians in general?
Yeah, it's a great question. And I think one thing I just want to point out is that workshops aren't effective on a single basis, right? We know that a workshop can be impactful and inspiring and empowering, but that it doesn't lead to long-term change if there's not a long-term commitment to behavioral change. So if folks are trying to do this work, I'd recommend the big top books that are in the field, that are out there. So you want to talk about race is a great one related to race. Googling common microaggressions related to identities in which you hold privilege. So for example, me Googling frequent racial microaggressions or frequent cisgender microaggressions would be a great way to figure out where are my areas of less awareness. And then finding a team or another person that you can meet with on maybe an every other week basis, even if it's for 30 minutes, to talk about upstander moments that you took and upstander moments that you didn't take, moments where you were a deer in the headlights, moments where you wish you had said something different, a group where you can process that and brainstorm, what could I say next time? We do that in all of our multicultural psychology work with groups where we check in on a regular basis with that very question. And that seems simple, but can lead to hours of conversation every time we bring it up, and we never get through the whole list. So once you start looking, it's like the Matrix. I don't know if it's the red pill or the blue pill, but once you start seeing it, and it's good to have people to process that with.
And one thing I want to bring up is, I know, Lauren, you and I have talked a little bit about this, is like, how do we make sure the space is safe enough that when we talk about fears, concerns, things we think we did wrong, we are able to promote learning versus shame? And what I mean by that is that, I know that there has been so many times that I've witnessed, even here at our clinic, whether it's among patients or you and I have talked about just like, I've said to you, like, oh my gosh, I don't know how you still hold that space if someone's doing that old school exposure that like they shouldn't be doing anymore. But like, there's one way where we can create an opportunity where it's a place to learn and for us to grow. Or if we kind of condemn someone for doing certain things, right, that's going to shut them down, and that's not going to create an opportunity for growth. And the reason I think this is really important for us to touch on is that it's critically also important for patients, right? If a patient feels like, I can't share with my clinician how this makes me feel because they're just going to say like, oh, well, too bad, it's the work you need to do, or like, this is how it is, compared to being able for like what it feels like for us to have to recognize in that moment, like, oh my gosh, like, thank you for bringing this to my awareness. And like, let's talk about how I can also better serve you or better understand how you're feeling. I want to hear a little bit about any thoughts you have of like how as clinicians can we put our guards down when our immediate response is like to defend what we do and to justify why we do certain things. How can we change to a lens of, like we talked about early on in the session today, of just growth?
Yeah, and I think all of these skills can be helpful for clinicians and anyone. So anyone watching this that's trying to do better in the identity realm could benefit from these skills. I think that the terms that are coming to mind from what you're saying, Liz, is the difference between a calling in versus a calling out culture. So a calling out culture could be understood as a period at the end of a statement or in the middle of a sentence. So that was wrong, or this is how it is, or you just have to suck it up and do it. It ends the conversation. It signals that there's a right and a wrong, and it can lead to, as you said, shame, guilt, and silence. Calling in, on the other hand, is like putting a semicolon or a comma at the end of a statement and invites more conversation and dialogue. So this exposure is so hard, and let's link back to your values and figure out, why are we even doing this in the first place? Or, hey, that thing you just said, that gave me, that made my stomach drop. I think there might be an identity related aggression in there. Would we be able to explore that together? Or, I didn't like the way how that just came out. Let me think about a better way to say that. So we're showing that we're able to share things without having all the answers. Say we were the one that was hurt or wronged. It's helpful to just be able to say, that didn't feel good. I don't have all the answers, but I just want to throw it out there. It keeps the conversation going without adding shame. And I think another thing that folks can do is, if you are a leader within an organization, trying to model your own mistakes and ability to share them with the team and get feedback. So sometimes I'll ask the other directors of the clinic, Would it be okay for me to give feedback on this to you in the next staff meeting so that we can all process it together and people can see you getting feedback and that that's okay, versus me giving feedback to someone that's brand new and terrified of messing up. So the more we can as leaders show humility and humanity and growth, I think the more it becomes a part of the culture of the larger clinic.
I love that.
I want to touch on a point you made earlier too. While you were talking, I was thinking you were saying like, especially a lot of people in the OCD wing, just this is the first time that they're asked some of these questions or they're going through an intake like that. What would you say to someone? Because it seems like, some therapists are thinking, okay, it's OCD. They're coming in for that. They're not coming in for other types of therapy. Why do you see in the clients that have OCD, this is valuable? I mean, I have my own opinions why it's valuable, but you're definitely more of an expert in this field. So I'd love to learn from you. Just like, what do you see in the practice that people from OCD really appreciate and how it helps better their care, and why OCD clinicians specifically should be invested in this type of work to better serve clients? Yeah.
And can I add in too, just like, I feel like there's this unspoken pressure for OCD clinicians. I don't know if you guys feel it, of like, you're an OCD clinician, like you have to jump right in, you have to do ERP, you have to do this work because like there's this like, oh, it's only supposed to take 12 to 16 sessions and we're supposed to get you better quickly and it's goal oriented. And like, I wonder if for clinicians too, it could feel uncomfortable to like slow down and to meet you where you are and to get to know individuals, because it feels like, oh, then am I doing talk therapy? Then am I doing, right? Like, love to hear all your thoughts.
Yeah, so I think the first place my mind is going is just setting the historical context. The field of OCD has been spearheaded by white, cis, I'm presuming straight men for the whole history of time. And that's no shade, that they've contributed wonderful things. And it's no surprise that this is the first time we're starting to really get headway talking about identities in OCD work, right? It's only been the past few years that it's not just Monica Williams and a couple other people talking about this, right? So just adding some compassion in there, it makes sense given where we came from, that this feels foreign and like totally counter to what we've been doing. I will say that doing the addressing framework in an intake session can take 10 minutes or less. And it might be the last time you ever talk about identities. And it can still be really impactful and people can really appreciate that you asked. It opens up the client's perspective that your therapist can see you as a full person outside of just your symptoms. And even if you don't ever talk about the other identities, just to know that your clinician knows who you are and is curious about that, I think can build a lot of immediate trust and can make a bond where that we know is extremely beneficial for successful ERP, and maybe even make the process go faster. We know that there's a huge lack of diversity in OCD treatment. So folks who present for treatment, and a large dropout rate or lack of benefit from OCD treatment for folks of color and folks with other marginalized identities. So I'd ask, maybe this is why, maybe this is part of the reason that it hasn't felt inclusive when folks do show up. And then lastly, in terms of how it can be helpful, Chris, I think that the topic of the overlap of OCD and trauma isn't out of place here. We know that having marginalized identities is linked to all sorts of trauma, including social trauma, rejection, physical trauma, violence. And so if we ask about those identities, we can start to get a better sense of what traumas might also be present that can slow down the OCD treatment process. And it's important for us to know that up front and be able to address it nimbly and quickly as it's coming up. Finally, just thinking about imagining a Black client coming in for treatment and having a white person saying, this is how we do the treatment, this is the one way, it's 12 sessions, can feel pretty oppressive. So if we're not doing that extra step to name that we're aware that identities are in the room and ask about them, it can, I think, lead to a lack of trust and a feeling of low support and awareness.
Yeah, one thing I wanted to add to it where I see it's very helpful is family culture. Obviously one of the work that we do as OCD clinicians is really educating the family on why accommodation and why reassurance giving and all of that isn't helpful. Because I think, most parents see their child or their loved one, if it's a husband, wife, et cetera, husband, they see that their loved one is in pain, and our go-to reaction is to help. And so a lot of the education is explaining like how to help and love your loved one and not support the OCD. And what I found is like different cultures address that issue differently. There's some cultures that it's like, no, like you have to do this and that. And I think if you don't look at culture or understand, I just keep telling the family members to stop doing that if they're not willing to do it because it doesn't feel right, is not going to be helpful. And so I think that that's where, sometimes there's that blind spot that us as a community can work on, because there is different kind of family ideals of how to support someone going through any kind of health issue, and just yelling at somebody, stop, isn't helpful. So I was wondering too, does family members sometimes get involved in this work, and do you find that helpful as well?
Yeah, absolutely. I think your point is excellent, Chris, that if we just yell stop without having ever asked the question of how is this similar to how you would treat your family member if they had a broken leg or different, can be oppressive. So instead, if we are to say, okay, stop this behavior, but able to say, but instead try this, because we've done some sort of cultural interview, that could be very empowering. So for example, saying, here's the psychoed on OCD. Tell me how what your family culture is like. Again, that could be 10 minutes. How do you support each other? What do you feel like you have to do as a mom in this family? And then say, okay, so I heard that you want to show a ton of support and and have a lot of communication when the person is struggling, and your son is struggling right now. So instead of answering questions when he reaches out, could you say a statement of support? I'm not going to do this. I love you. I'm not going to answer the question. Which again, that's a similar recommendation to how we would probably say to any family, but figuring out, okay, what are your values and how could we give you an alternative statement as opposed to just, no, don't do this. So no, but how about this? That's housed in their cultural practices or their family practices.
100%.
Well said. Yeah.
Yeah. I love all this. I know it's so important. And I think that we could do 100 talks on it, just because like it's every time we talk, I'm like, oh, I could ask 500 more questions. But I do want us to talk a little bit about how we specifically see this playing out in OCD work and in OCD treatment when we jump into and think about ERP. And so let's start there. Like, what are considerations that clinicians really need to keep in mind related to client identities and also gender identities as a whole when we're thinking about ERP and when we're thinking about OCD treatment?
Yeah, I just wish I could push play on the recent Lunch and Learn that you did on sexual orientation OCD, because I thought that gave so many awesome examples that I've used many times since. Some of the ones that stood out were that we might have been taught that saying racial slurs or it would suck to be gay or I'm gay as it's a bad thing is what we were taught to do, and it can be oppressive and is oppressive. And we don't have to do that to have successful ERP. So instead of saying the racial slur, because that's the thing I'm afraid to say, digging down underneath that and figuring out what is the core fear, right? The core fear isn't of saying these words out loud. The core fear is I might be a racist, right? Or I might not know my sexual orientation, or I might be a bad person. So figuring out, can we target that core fear without saying things that are harmful or denigrating to communities that person might be a part of or might not be a part of? Can we instead engage in empowering acts or practices? I loved the example of drawing a giant pride flag and putting that on the wall, instead of saying like, I'm Lauren and I'm gay, and putting it on the wall as if that's an embarrassing thing to do. Reading about different groups, attending community events. Chris, you were talking about volunteering. I think that's an awesome idea. Again, as long as it's done in an empowering way, not as in a voyeuristic way.
Yeah.
Yeah, and I was talking about this morning with a clinician. Is we were talking about the power of uncertainty, but it also like led me down this long path of how do we understand uncertainty and what does it mean? And I think sometimes when we say uncertainty, a lot of like we may hear it as like a one size fits all for all OCD or for all exposures. And it's like, no, like what we actually, that's not what we mean, right? But so for example, when we're thinking about sexual orientation OCD, do we really need to have patients writing scripts of I may or may not be gay? And is that actually damaging to a community that might mean a lot to them? Or is it more valuable to go to lunch with one of your friends who's is a different sexual orientation than you are? Is it more important to attend a gay pride event that you've been wanting to go to that you've been avoiding, right? And how can we make sure that we're targeting the same things, right? Which is it's really about not letting OCD dictate values, decisions, life, without us making it more stigmatizing, right? I think what Chris was saying too, I talked about this in that last live stream, was, should we be using individuals who, in Houston, one of our big shelters is the Star of Hope, but like, does it make sense to use them as a prop for an exposure that like, oh, go shake their hand, go give them money, compared to, hey, why don't you go feed those that are hungry, if that's a big value to you, during the days that there is, meals offered to the public or whatever makes sense.
Yeah. And I think one other consideration that wasn't touched on in that talk is thinking about what identities does this person hold, and is it as safe for them to do this exposure out in public as it would be for a straight cis white person. So for example, if it's to make a fool of yourself or ask an embarrassing question or interrupt someone or give something back that you just bought, exposures that might be really dangerous. It's important to think about, would that be dangerous for a Black person to do? Could that lead to some microaggression happening or major aggression happening in the moment that could be really harmful to that person regardless of their OCD treatment, right? So are we setting up patients for dangerous situations if we're not considering their identity in doing public exposures or exposures involving other people? So for that, we at the clinic made a treatment guide that divides traditional treatment targets, so behaviors or actions that I've been avoiding to reduce anxiety that I would benefit from exposing myself to or restructuring, and then identity-based stressors, so behaviors or actions that I'm avoiding or hypervigilant due to my identities and safety around those, and really writing that out before starting exposure treatment. So for example, a traditional treatment target might be something like touching things that may be contaminated. An identity-based stressor or avoidance behavior might be not holding my partner's hand in a public setting where I think I might be a target or in danger. So just trying to really think carefully about what are we asking our patients to do and how might their addressing identities interact with those behaviors to make them safe or less safe. Patients will probably have a really good idea of what those are, but giving them the space to lay that out before just going to our typical list of things to do when someone has sexual orientation OCD.
We need you to write this treatment manual for all of OCD, because I'm literally like, oh my gosh, like we do so much wrong and there's so much to learn. And I love what you ended with is talk to your patients, right? What for, like, let's differentiate what is OCD that they want to do, like what are targets that are important to them, that values they want to live by, versus you're asking me to do something that I'll do it because I feel like I should, but like it actually triggers other responses or other fears for me that may not be safe, right? May not make sense. Sorry, Chris, I interrupted.
No, it's all good. I mean, what I was thinking while you were talking, I mean, it was definitely like, a blind spot to even to me. And I'm like, like I said, this lunch and learn is selfishly for me because I'm learning so much. One of the good points that you made is, I think, another thing about OCD therapy, besides what Liz was saying earlier about like rushing in, we're sort of, expected to kind of, for our clients, have like a treatment manual. And I know, like, going through graduate school, going through undergrad, going through all the other trainings I went through, it was always like, we're there to create a safe space and let the client kind of guide us. But in our work, if we let the client guide us, especially somebody starting out in OCD treatment, they're like, all right, cool, we're going to go take 3-hour showers and wash our hands for all day, and so we have to kind of come in and guide that. But you're right. I mean, one thing that would be so powerful in that assessment that you're talking about is to see, is like, is this, exposure going to make the person feel safe? I might feel safe doing it, but who I am is very different than who my client is. And so letting the client have a voice in the room for sure, and just making sure that that's something they're comfortable with. One of the things that was talked about last live stream that you're adding on to so much is, I think, like, when I first entered the treatment, the way that some people, in the community, like, talked about it, was almost like it was like fear factor, like, we're going to go shock you into getting better. Yep. But what I'm learning so much more as I think all of us clinicians have so much to gain, that we don't use people for props. We don't use communities for props. And so somebody who's struggling, for instance, with sexual orientation OCD, if they haven't gone to the gym because they're really triggered, like, let's have them go back to the gym versus them wearing like a tight shirt and walking around LA throwing up like wrist and calling that an exposure. So I think there's so much that can consistent be learned from talking to our clients and seeing what their values are and what they're comfortable with and feel safe doing.
Yeah.
And can we talk for a second? I would just love to talk a little bit about, and I'm with Chris, this is always like, it ends up being our own clinical consultation too, that we're like, we're learning so much. But the concept of overcorrection, right, when in OCD treatment, is that for, I think, a long time, the traditional OCD or ERP model for OCD treatment was, we always need to overcorrect, right? So yes, we're going to do extreme exposures, but we do them because we want you, like, we have to go above and beyond for things to feel normalized. And as someone who lives with OCD, Chris, I'm sure you could share your own insight. I've always really struggled with that concept. It didn't, even in my own treatment, it was like, but why do I need to go to that degree, to that extreme, right? And what I've learned as an adult now and clinician, and the more, is, for me, actually, overcorrection for my OCD is doing normal things, but leaning into accepting the unknown, right? Which is actually what people without OCD do every day. They just don't have to acknowledge it. And it still feels like overcorrection for those of us that live with OCD, because it's so in our face, right? It's so scary. But I'm not a believer that we need, for someone with, say, like, urine-based contamination fears, I don't think we need to have a water gun fight with urine. Like, I don't, because I wouldn't do that. Like, I have rules around exposures. It should be something I'd be willing to do. It should be something that isn't a surprise and something we both agree upon that makes sense. And I think this is a really big piece too, is sometimes actually our patients are telling us that we're overcorrecting when, like Chris was just saying, for us, we're like, oh no, like, any of us would do this. This is totally fine. Does that make sense? And so I would love to talk a little bit about just, are there any, and I don't know, Lauren, if you have found in practice, like, are there any red flags or something that as a clinician would indicate for you, maybe we're overcorrecting here, or maybe this isn't actually values-based for the patient. We need to slow down. We need to, like, whether it's the physiological responses or language clients might use with us.
Yeah, I think that I've appreciated you bringing that up multiple times, Liz, about, questioning the overcorrection. When I think about what has the overcorrection model, how has it served the OCD world? To me, it seems like overcorrection is helpful when, I don't want to say helpful. Overcorrection can be effective, in quotes, if there isn't true willingness on the patient side. So I feel like the overcorrection model is kind of an oppressive model. Like, this is what you got to do. Come on. I'm like pulling your hand into the bathroom and putting it in the toilet. Like, it's this kind of flooding approach that, and it's always been explained to me, is we have to overcorrect because when you go back home on your own, you're not going to be able to maintain these gains. So at least if you slide back 20%, like, you'll be doing pretty well, and then you'll be doing normal things, right? So I would say to that, well, if the person you're working with was truly willing to lean in all the way on the exposures you were doing, wouldn't they be able to do that on their own at home? Like, is this overcorrection a partner to forcing or coercing patients into doing things that they're not truly willing to do? And is that what's inspiring it? So if we are to have a better pulse on our patient's willingness, we ask that before every exposure, and we try to really ask it honestly, like, what is your willingness to let all this anxiety in that you think is going to come up with this exposure? And if it's not high, we pick a different exposure, because we have found that if we lead with client willingness and not SUD scores, we have long-term change, which I know others have seen and proven with research. So I think that willingness model is a more patient-centered model, and goes hand in hand with asking about things like identity, because if someone knows that you're thinking about them as a full person, they might be more willing to say, Liz, you asked about my racial identity, and it's coming up in this moment as something that feels dangerous. If you've never talked about it before, it would be really hard to bring that up when SUDs are at 100 and your therapist is like, are you going to do it or not? This is the treatment, right?
Yeah. No, that makes total sense. And I talk about this a lot, in the sense that, I do think that for those of us with OCD, we can always justify why we never should do any exposure, right? Like, oh, well, I don't need to do that, Chris. Like, that doesn't apply to me. And it's like, yeah, but right. And I talk about this a lot when I struggled with a lot of my contamination-based fears around bloodborne illnesses. And, my clinician, the top goal was like, let's go to an HIV clinic, or in Houston, we have this really awesome thrift shop where they do HIV testing. And my response was like, but I don't know that I need to do that. Like, that's not something that would necessarily be like impact my life if I don't do it. But guess what? I actually found later on it did impact my life, in the sense that I really wanted to go on a mission trip. And I found myself looking up rates of diseases I was afraid of, and like basing what mission trip I could go on based on which one I felt was safer. And now all of a sudden it conflicted with my values, right? And it was like, okay, now I see why I need to do this exposure that might feel maybe more overcorrection, but it directly impacted my values, right? Things that are important to me. I don't want OCD making a decision of a mission trip I go on, or things that are valuable and important. But the second piece of that same exposure for me that I do want to talk about is, to this day, I carry a lot of shame and guilt around feeling like my OCD made me believe certain individuals or certain places that individuals may or may not have visited were contaminated. And I knew it was OCD, but there was so much shame in like that. Just it conflicts so much with my values of like, I wouldn't want any person to ever feel that I think they're contaminated, or that they're a danger to me or anything, but that instead it was my OCD. How do we address that? Like, how do we make sure we're not just doing ERP and forgetting about the shame and guilt that comes along with a lot of the obsessions many of us feel?
Yeah, I think it makes sense to name it and talk about it. And we can also contextualize it for folks to say, it's not just you that thinks that gay people are contaminated because we are told that gay people have HIV. Like, these are stereotypes in society that have been perpetuated, that you are brought up to believe. So of course, your mind is going to go there. OCD is going to use that. And you as an empathetic person is going to have a problem with that. And there's all the steam OCD needs to get going. And let's again not forget that this is what you were taught to believe. So I think instead of saying it's just OCD, it's just OCD, it's just OCD, it might be more powerful to say, this is what you were socialized to believe.
Yes.
And your OCD has used that and amplified it and is making you think about it all day, every day now. And we have to own that is a stereotype that we hold, that we're actively working against. So I think there can be increased self-compassion and humanizing and a path forward if we don't deny that this is a real part of what we're taught to think.
I've been in therapy for 20 years and no one's ever told me that or addressed that with me. And it's so powerful. Like even just the way it made me feel right now to like be able to validate that, like, let's not just label it as OCD, because it isn't just OCD. It's also like it gets at the core of who I am as a person and causes so much guilt and shame that like I need to address both. So that's awesome. Sorry, Chris.
No, I was just what I was going to add to it. I was actually talking to like a queer colleague, and one of the struggles that they have is that a lot of times like clients will want to work with them and then start like inquiring and getting reassurance, like, well, I know you're queer, am I queer, all of that. And one of the things that I think sometimes us therapists were beat in our heads is like, never self-disclose, never talk about ourselves. And obviously we want to make the clients our front and center, and it's 100% about them. And what you just said is so powerful, because there are clients that have come in and like, there's this unspoken thing. And then when they finally open up and they're like, I feel so guilty, like I have fear of HIV, and because you're gay, like I feel like you might have it and I don't. And it's just like, but don't, it's like, if we don't have that conversation, I can see the pain in them. And it's like, what you were saying right there just totally clicked with me. It's like, I do have those conversations, or clients that come in with sexual orientation OCD and then ask to work with another clinician because I trigger them and stuff. And then there's a lot of guilt and shame as they get better and they're part of the group and they see me at the clinic and, all of that. But what I think is so powerful about having that conversation is, one of the things that I keep trying to tell my clients is like, you are not the OCD. The OCD is something you just happen to have, but it's not who you are. And so when we have those open conversations, when we normalize it, when we discuss it, especially coming from a place of like openness, support, and sympathy and empathy, you do see that person, like feeling relieved. And I think that's such a part of the disorder, is people feel ashamed of having that kind of ego dystonic feeling, yet that's what kind of keeps them stuck in the OCD, because they don't want to open up to their clinician. Or like, we have a Black clinician at our center, and like, clients will say to me, like, who have intrusive thoughts about yelling something out, like, I feel so guilty, like I wanted my sessions to be when they're not at the, and it's like all of that. But I think having that open conversation can make somebody feel better about recognizing that that's the taboo nature of the disorder. It isn't you as a core person.
Yeah. And same with our socialization, right? You are not your socialization unless you're not actively resisting it, right? So if you are able to recognize it, name it, yes, I was taught that gay people are contaminated and I don't feel good about that. That feels shitty. I don't like that. And these are the things I'm doing to counter that, noticing and recognizing my own bias and how that links to my OCD is that's good work.
I love it.
What I wanted to add quickly about the overcorrection, one of the things that really helped me with my therapist, because, I feel like I got my therapy a while ago, and I always think I'm always like, shout out to Karen Pickett, because she did so many of these good things before that they, talked about. What I always liked about our overcorrection, because so much of my OCD was so resistant that I was like housebound and didn't leave the house. So I had to go above and beyond.
Oh yeah.
I felt that the overcorrections were kind of like the treatment. I never felt like I was put in like an unsafe, humiliating, awkward, almost like I didn't feel like she was like getting pleasure in like seeing me be embarrassed or ashamed. And I love, before ACT was a thing, before, it was discussed when I was getting treatment, I loved that about her. And that's one of the things that I've tried to model as a clinician, is like, I can have my clients do things because I know that's going to happen in the future. Like, a client who's really afraid of driving themselves because of hit and run OCD, I visualize that person being independent, driving to their job or driving to a friend's house. And so having us drive and then eventually driving on a freeway or driving around a school, to me, makes sense, because that's inevitably going to happen. So I think that we can have those exposures live into somebody's values and have them go to a place they're comfortable with, that they see value in, versus here's a bunch of horrific things that pretty much none of the population wants to do, but because you have OCD, you have to like you said, play in urine, or if I have a client with fear of dog feces, it's like, we don't need to overcorrect to the point that they're picking it up and rubbing it on their face or something that I've heard. Yeah, so it's,
but
I think
do
that's
we
what
need
people
to lean
need
into
to know.
the fact that like we may have stepped on an area that had dog poop once, right? Or there could be dog poop on my foot, or picking up dog poop with a poop bag. Like those all are valuable, important activities that make sense. And so, Patricia, I see your comment about, aren't overcorrections helping with avoiding OCD to spread to spread more in other fearful areas, and then normal exposures get easier. I think, yes. So I don't want anyone to hear me saying we don't need to do our top level exposure. I 100% believe we need to do our top level exposure, right? If there's any piece of us that's avoiding an exposure due to fear, or avoiding an activity due to fear, we 100% need to do it because we don't want fear to win, right? It's about approaching fear. But there's times where exposures don't need to be done the way we may have done them in the past for us to get the freedom, if that makes sense. So, for example, in the past, I have been in clinics where we may have written racial slurs because if we had an intrusive thought of what if I'm having conversation with someone of color and I say a racial slur, the exposure might be go ahead and write down racial slurs. I'm going to challenge that, like, why do we need to do that exposure? Isn't the more important, valuable exposure having conversations with people of color and leaning into the uncertainty later that, like, I don't know for sure if I didn't say anything inappropriate, or, I don't know for sure that I did or didn't say everything perfectly in the way I wanted and still moving on with your life. Like, that's actually going to help get at the core fear and address and help you live by your values much more than writing a racial slur is, because again, writing a racial slur goes against our values and who we are. That's what we would never want to do that, and so Callie, Chris, and I actually submitted a talk to IOCDF really focused on this of like, do we have to be comfortable with our worst fear coming true in order to have overcome it? And what we mean by that is there's so many times where we've had patients come to us, and probably ourselves included, where it's like, oh, well, you have to accept that you may be a pedophile. And it's like, well, but that, like why? Like that, like being a pedophile is one of my worst OCD fears. Why would I need to accept that? And if you're telling me I need to accept that, like, I don't really want to do treatment. Like that's how I would feel. Right. And it's like, okay, so instead, what I'd actually rather you do is be able to spend time with kids, spend time doing the things you previously or right now might be avoiding. Right. That's more important. And to lean into the uncertainty that, like, to quit trying to solve, to quit trying to be totally sure that you're a good person or you're not a pedophile. Does that make sense? Like I gave this example the other day that I woke up in the morning and had an intrusive thought around my daughter, a sexual intrusive thought that was pretty vivid. And in that moment, leaning into uncertainty for me just meant accepting the thought, right? Just kind of saying like, okay, like I have two choices right now. I can acknowledge the thought and the way it made me feel and move on, or I can try to solve the thought and try to understand why to have that thought. What does it mean? Why, am I a bad person? One path, I'll be stuck all day and my day will be ruined. The other path, which I did, was like, no idea why I had that thought, but I'm still going to move forward. And I ended up taking a shower, coming to work that day, right? And by the time I got to the office, I forgot I even had the thought. That is values-based ERP, right? I didn't try to suppress the thought. I acknowledged it was there. But I didn't really need to spend the day leaning into like, oh, I probably am a pedophile and I probably enjoyed that sexual thought about my daughter. Like, do y'all agree with that?
Yeah, I call it the Rubik's Cube. Like your OCD is handing you this Rubik's Cube right when you wake up and you're saying, yeah, that's an impossible puzzle to solve, or I could try to solve that all day, maybe get a few pains and then it might get all undone, but I'm not going to pick that Rubik's Cube up.
Yeah.
And I think the other piece of what you were saying, Liz, that stood out from the last talk was our goal isn't to get more comfortable saying racial slurs.
No.
Our goal is to be able to have conversations, to walk where there might be dog poop without tracking that all the time.
That's right. And that's what uncertainty is, right? Uncertainty is about being able to live freely. It's about OCD not getting us stuck, OCD not making decisions for us. I talk about this all the time with Scrupulosity. If uncertainty meant we had to accept our worst fears, that'd be like us saying to a Christian who has scrupulosity, okay, by the end of treatment, I want you to be comfortable with the fact that you might not be a Christian. Like, what? No, like that person would say, like, absolutely not. Like, this is an important value to me. Instead, I want to be able to engage in my faith practices that OCD is taking me away from. So what's the goal of treatment? The goal of treatment is that by the end of treatment, your OCD doesn't dictate your faith relationship, and that you're able to live by your faith the way you want to, and that your genuine faith relationship becomes what exists way over an OCD dictating or making any of those decisions for you, right? And so that's where across the board, can we start thinking about, are the exposures that we're doing, do they get at the core fear, or is it just like, oh, let's just go worst case scenario because that's going to somehow like make it better? But does that worst case scenario marginalize groups further? Does it make us experience more shame? And is it even needed to get us where we want to go?
Yeah, to quickly touch on like the scrupulosity piece, it's like, I think when we talk about like older exposures and the way that people think about it, it's like, clinicians might have somebody like rip pages out of a Bible or something, and it's like that's not going to be in somebody's value. Or it may, I guess, but I mean, for a majority of my clients with scrupulosity who are Christian, they're like, that's not what I want to do. I would never like rip out pages or write horrific things in the Bible. But what about if we just had them go to church? Maybe they've been avoiding church for the last 3 years because they were worried about having an intrusive thought during church. Why don't we instead have them work towards what are the steps to get back in church? So I think, just to clarify for your question, Patricia, it's not that we're not going to have somebody go in and lean in to do hard things. It's just, can we have them do something that's value-based, that is going to lead them towards the life they want, versus kind of this like shock value treatment where it's like, oh, you're ripping out and you're, saying horrific things about God in a public square.
Totally. So this has been so awesome. I know it's noon. I want to be cognizant of everyone's time, but Lauren, any final comments or thoughts for you? And I guess the way I'll end is just by saying thank you. Thank you for the work that you're doing, the work that you've done, and the way it can really inform future practice, not just for all of us that are clinicians, but more importantly, the way it'll positively impact all of those of you that are out there seeking care.
I would just say that every little step makes a difference. So if there was one behaviorally specific thing you took from today, try that and then try more. I know we covered a lot of things. And thank you again for the invitation and for using this platform to have this important conversation.
Yeah, what I just want to say is I hope everybody reads your book. Not that I'm, your publisher or anything. I just think that these are the kind of things that people in our community as clinicians need to be reading. And I think you made a really good point earlier. It can't be a workshop one time and then you call yourself something. It has to be continued work. You were so valuable today. I do believe that people in our community and clinicians are going to gain so much from this. So thank you so much for your time. We really, really appreciate it here at Lunch and Learn. Thank you so much.
Thanks, y'all.
Thank you.
Take care, everybody. Everybody kick OCD's butt today.